Ladies and gentlemen, I am Dr. Raghuram Rao. I am from the Central TB Division and I am a public health specialist by profession. And today I will be speaking about the various services offered by the tuberculosis program in India on the diagnosis, treatment, supportive care and prevention of tuberculosis. The tuberculosis program was initiated in the country way back in 1961, and the efforts were then based on the newer experiences and the newer evidences that were available, and with the introduction of DOTS, the program was revised and called as Revised National Tuberculosis Control Program, and this was launched in 1997 and then was expanded across the country. Based on newer initiatives like the HIV program coming in, the collaborative activities, and then the drug resistant program coming in, these programs were introduced in 2007 and then expanded to cover the entire country. The program provides quality assured diagnostic and treatment services free of cost to all TB patients, including the supportive mechanisms that is required to ensure that the patient continues and adheres to the treatment regimen and ensures completion of the entire duration of treatment. The program has now currently developed its strategic plan called the National Strategic Plan, and it has been made from 2017 to 2025 with the elimination of TB by 2025 as the goal of the program. The current session, we will have a look at the diagnostic services, the treatment services, the drug resistant treatment services and TB HIV services. We will also talk of preventive strategies and the social support and universal coverages and social protection that is being provided under the program. We will also have a look at how TB cases have to be notified and what are the ICT enabled services that we have under the program. So, the Revised National Tuberculosis Control Program is implemented by the Central TB Division at the apex in the Ministry of Health, and under the Central TB Division the program is implemented by the state governments through what is called as the state TB cells. The National Central TB Division is supported by national institutes and is also supported by expert advisory groups, and there are national committees and advisory committees for diagnosis, for treatment, and likewise for all the other programs. The state TB cell also has a similar structure where the state TB cell is supported by a technical unit called the State TB Training and Demonstration Center, STDCs, and this is the technical wing which takes care of the training and the laboratories like the intermediate reference laboratory, the reference laboratory for the state level. The other state level structures that are there are the IRL is also attached to what is called as a culture and drug sensitivity or drug susceptibility testing laboratory, culture and DST laboratories for diagnosing and drug resistant TB cases. The state structure is then decentralized and it is established at the district level, where we have a district TB center, and at the block level a tuberculosis unit is established for every 2.5 lakh population, and of course it is relaxed for difficult and terrains and northeast areas and tribal population. And then at the below the block level there are units called as the designated microscopy centers, which do sputum microscopy and do the diagnosis for TB. These services are available, these centers are established for every 1 to 1.5 lakh population, and in difficult areas for every 0.5 lakh populations. And below the designated microscopy centers are the places where the doctor is physically present, like the primary health centers, where it is used for diagnosing and initiating treatment for tuberculosis. The various diagnostic services that we have apart from sputum microscopy is the advancement with the newer molecular diagnostics that have come into the program, like the gene expert machines, which is called as the cartridge based nucleic acid amplification test. CBNAT is the the technology for that. Then there are radiography, like chest x-ray is used as a diagnostic service, and TrueNat is a newer molecular diagnostic that has come in, which is also CBNAT, similar to CBNAT. It's again a cartridge. It's not a cartridge, but it's a chip based diagnostic tool, molecular diagnostic tool. Based on these different diagnostic tools, the program also has certain technologies, high-end equipments for diagnosis of drug resistant TB, where the culture and DST services are provided in those laboratories. So there are equipments called as midget and other equipments for doing these high level investigations. As a strategy, the program also implements what is called as an active case finding campaign, where the public health workers go out into the community and do outreach activities and go house to the at-risk population to screen them for tuberculosis. Also, mobile vans are used for these activities, and the mobile vans are equipped with digital X-ray and microscopy services. So, like I said earlier, the case finding strategies for identifying a new case of tuberculosis. Of course, there is the basic passive strategy where everybody coming into the hospital and coming who is symptomatic and seeks care in the public health facilities is provided diagnostic and treatment services. Then in certain settings, there is what is called as intensified case finding strategy. Now these settings are like where people are more prone to develop tuberculosis, like the HIV care setting, where the people living with HIV come to seek services, and being prone for tuberculosis, there in those population an intensified screening for tuberculosis happens. Similarly, in diabetic clinics or in the nutritional rehabilitation centers and these settings, there is intensified case finding efforts for identifying tuberculosis. And the ones who do not come into the program and are at risk, to cover such population, the program has implemented a strategy called as active case finding. So it targets different high risk population, like people living in slums, the tribal population in prisons or other congregate settings like orphanages, old age homes, and in such settings the public health workers go out into the community and they screen them either through mobile vans or physically going and providing services in terms of doing symptom screening and then other diagnostic services required for it. The various tools that are used for diagnosis of TB, of course the traditional smear microscopy is what has been used over the years for diagnosis of tuberculosis using different staining technologies like Ziehl-Neelsen's technology or fluorescent microscopy. Now these are now of course has limited sensitivity, so there are newer diagnostics that have come into the program, like the cartridge based nucleic acid amplification test, then culture investigations. There are two types of it, solid culture and liquid culture investigations that happen. Then there are other supportive tests to help confirm diagnosis, like chest x-ray or radiography, and then tuberculosis, the TST skin test, the IGRA test, the other for extrapulmonary cases, the biopsies that are taken from the neck, the fine needle aspiration cytology, histopathology. These are different ways to support case to be a confirmed case of tuberculosis. The molecular test also has the potential to identify drug resistance. in the tuberculosis bacteria. So there are drug susceptibility testing, certain higher end equipments and laboratories are established, and CBNAT is one of the technology which gives a rapid diagnosis on not only for tuberculosis but also for rifampicin resistance. So it gives a result in as early as 2 hours. So there are more and more, there are around 628 CBNAT laboratories that are established across the country at all and practically covering all districts, and at the district level facilities have been provided with these equipments. Then there is line probe assay, and also there are growth based tests like the culture which I said earlier for solid and liquid culture to not only diagnose TB but also to identify drug resistance. For pulmonary TB, the algorithm for diagnosis is whenever a suspect or a presumptive TB case is identified, he is offered smear examination, sputum smear examination, and if he is not chest symptomatic and has no sputum and is still symptomatic, having other symptoms for tuberculosis, he is also offered an chest X-ray simultaneously along with the sputum smear examination. And based on those results, if the sputum smear is positive, he is directly started, he is considered as a microbiologically confirmed case of tuberculosis and initiated on treatment. And if the sputum smear is negative and chest X-ray positive or suggestive of tuberculosis, he is offered molecular diagnostic, being a higher sensitive test. So the technology has the capacity to identify even very low levels of bacteria in the sputum sample. So it helps in microbiologically confirming the case of tuberculosis. And based on these, even if the chest X-ray is negative or is not suggestive, but the patient is symptomatic, again the other investigations that would be required are available for the clinician to confirm his case, and he can clinically diagnose and say a case of tuberculosis, even though if it is not microbiologically confirmed. But if there is high suspicion of tuberculosis, the medical officer has the options for deciding and initiating the treatment. For extrapulmonary cases, when the site from the site a specimen is collected, like FNAC for a lymph node or a pleural fluid or a CSF fluid, based on the type of extrapulmonary location the clinician suspects, and based on that sample, if that sample is available, it is offered directly. CBNAT is the technology that is offered now, and also it can undergo liquid culture. And if CBNAT is not available, CBNAT is a rapid tool, it gives results in 2 hours, liquid culture takes time. So based on the facilities available in the district, the sample is processed and identified as tuberculosis or not tuberculosis, of being microbiologically confirmed extrapulmonary tuberculosis. If there is no sample available but there is very high clinical suspicion, there are other diagnostics tools like CT scan or MRI and other supportive investigations. But if even in spite of all these things, the clinician feels that he has tuberculosis extrapulmonary, he can still even though it is not microbiologically confirmed, it can still be diagnosed as clinically diagnosed extrapulmonary tuberculosis and initiated on treatment. For pediatric cases, it's a little tricky because the child is unable to give samples, or so it is always difficult to diagnose pediatric case of tuberculosis. So however, with the advent of CBNAT, the specimens, if the child if it cannot give sputum, an induced sputum or a gastric lavage sample can be processed in the CBNAT platform, and it can detect positive or negative for tuberculosis. And even if other supportive investigations like X-ray, TST, and the likes are also used as tools for diagnosing pediatric cases. The the option of again clinical diagnosis of tuberculosis also exists now in this scenario, where the pediatrician, if he feels that this case is clinically suggestive of tuberculosis, he can initiate treatment, diagnose and initiate treatment. The different diagnostic investigations that are available under the program may not be physically available under one roof. So, the public health based on the infrastructure available in the hospital, it could, all these services could probably be available in the district hospital, but may not be available in a primary health center. So, in such cases there is provision of sample collection and transportation which is existing under the scheme, and so the sample, instead of the patient moving around, the sample gets moved around, including X-ray. Now in this era there is digital X-ray that has come in, so and telemedicine, teleradiology is also being used in some states. So these are the different tools that are used for diagnosis of tuberculosis in our country. Thank you for the patient listening to this session.